So I just want to use 1 or 2 minutes to explain two terminology as such. Some fresh flow is the word very commonly used. Some fresh flow means that you just can't see anything when you're doing the laser procedure. And I think it's important that you're using the same terminology. We do notice that in a lot of literature, that how those terms are used are different from one paper to the other. So I define as a fresh flow is that you can't see anything when you're doing it. However, that even in that circumstances, that you can see some changes later. Either that you just can see it by examining the patient, but or by doing something slightly more sophisticated, like occlusion imaging or OCT changes and so on. So endpoint management by Topcon have always encouraging the idea that by reducing the power and the duration, and then you don't see it while you're doing it. And in fact, you don't see it even afterwards when you're looking at it. But you do see it when you're doing an OCT and autofluorescence imaging. So I think there is something slightly different from that perspective. And the 2RT laser, I was very excited that they're showing some really interesting results that they can remove drusen and potential preventing progression. But again, they're using a very high power energy with a very short duration. And when you're looking at some of those slides, you also see that they do actually have some changes. They don't like to call it scar, but then I would call it RPE changes. That is scar in my head, but that is what you can call it, whatever you like. You can't call it coupe, it's not a car. But anyway, what we can try to do is that try to do the pulsing, deliver the energy, but without causing any visible changes. And that we have taken more than 10 years to get to that power and parameter. And again, I don't want to discuss the parameter today, and Quantel can share that our recommendation with you. So those are terminology out of the way. Some of these pictures that you've seen a lot before, and you might be in multiple of my publication. So basically, you treat the one eye, and then one laser session only, the edema goes away, and then without any scars that you can see. It's typical thing, simple stuff, very common. A lot of people ask, how close can I go? And again, our good friend Jeff Lottery actually said that, well, you can shoot the full V if you want. So I don't tend to shoot the full V deliberately, but you can go very close. As you can see here, that the macroaneurysm is very, very close, but then even treating that is absolutely fine. However, I wouldn't want to do so close on your first patient. Make sure that you know what you're doing first. So I can do handbrake turn very easily, comfortably. I wouldn't recommend my son to do it. And living in Germany, I drive 250 kilometers per hour on a daily basis. But then I don't recommend anyone else that who never done it before and then try to drive 250 kilometers per hour. So when you know what you're doing, you can go very, very close or hit the full V if you want to do. But when you're first starting out, get the power setting sorted out first. It does work in vein occlusion. Central vein occlusion is not great. I have to say that, and even branch vein occlusion, I have some hesitant how well it works. But again, you can see some cases that you got a little edema, and then without any injection, with the SubLiminal laser, and then you can treat that using the same protocol that we use with AMD. Although that I do have some hesitance about a much more severe central vein occlusion without using an injectable. Central serous, again, we're going to talk later, but I just want to flip through a few cases that how close you can go. So you can see here, you can get very close, and then you work, and then you get even closer, and you work. So these are kind of, we can keep on showing cases. Chronic CSR, it also works, but then you don't have really a clear leakage. It's more RPE leak. And again, you need to cover the whole aspect. It's not a typical focal leak that you can see, leaking all over the place. And then, when you do that, you can cover the whole area. And we actually find that with chronic CSR, you probably need to cover a slightly bigger area than just the leakage. Because we believe that the laser is inducing the stimulation of the RPE cell to make the RPE cell to work for you, as like we discussed earlier, about changing the microenvironment. So because of that, if you just treat this already sick RPE cell, might not be enough. And so you need to treat slightly outside. And indeed, that might be the reason that some people who are doing chronic CSR, the 5 megapulse is not working that well. And that might be the reason for that. And again, this is just like that, when you're doing more and more cases, you audit your result, and then you learn and you change the technique and so on and so forth. But CSR we'll discuss a bit further. So I would just try to skip that for the time being. So in 2018, I think DME might be due to branding occlusion, CSI work very well. What is not clear is that what if you got edema, how you link with anti-VEGF. And again, we are doing a clinical trial in the UK right now to comparing milder DME, whether that would work with laser or not. And then also we're trying to do another study to combine anti-VEGF with DME. So things that we're doing and working on. Back to CSI again, that in the PLACE study that they were using the 810 laser, the infrared laser, and here, 30% had a full resolution. We were quite surprised with the result. And commenting on what I said earlier, it might be that they were doing it in the older fashioned way because all this study was decided 5 or 6 years ago when we don't have the knowledge of treating a lot of cases, and whether that might be the reason that they don't get the result that other groups have managed. As you can see here that they seem to be superior in the first visit, but they're no different in the 7 to 8 months follow-up. But the resolution rate is very low, which surprised us in a big way. But in the PECO study, which is slightly more recent, and then they show that actually the difference is even smaller, if anything, that the laser is better than PDT. But again, it's a retrospective analysis, there might be a different patient group and so on. Macroaneurysm, you work as well, you previously published, and then non-responsive neovascular AMD. So when you've got an AMD patient, it doesn't seem to able to get them to dry up anymore with anti-VEGF. Micropulse stem seems to work again, and it was published on 13 cases, and we've done a few cases ourselves, probably more than 15, 16 now. Seems to work. Not everyone, but some of them do work. So something that we might be thinking that might be a reasonable thing to do. But don't only treat over the scar, but you need to treat some almost what we would call normal retina or normal RPE cell, because you really want to stimulate the RPE cell, but not the actual lesion itself. So it's got a different concept of how that might work. And again, then you can read the article by Jeff Lottery, and then you can see the different opinion of exactly how you do it. And that might be still the confusion in the literature. And then STEM group, Jeff have published a extensive review that they have treated over 500 patients, and then they claim that you just laser the whole posterior pole. So not just lasering the drusen, but laser the whole thing. And then they seem to have a very low conversion rate. But this is no control group, retrospective analysis, maybe have practice bias for argument's sake, just pure argument's sake, that those who have a CNV might not want to go back to see Jeff anymore. But obviously Jeff said that all his patients are very loyal, they all come back. So again, interesting, but it's striking data. And to me, at the moment, is without a randomized control trial, is something slightly not totally believable. But with the 2 RT laser result from yesterday that was presented in this meeting, it might be something that we can think about a little bit more. Another SAM group using laser for retinal pigmentosa, very small series, very variable data set. So therefore, that it's interesting to talk about. Whether it's real or not, I don't know. What else is possible? PCV is possible, drusen is possible, and then we are now in the Royal Free that we're doing another drusen trial to try to read, but we're going to do a randomized control trial to see whether that would work or not. PCV, we're going to my next speaker, we're going to talk about that, so again, that they will share that information with you in a moment. In summary, I think that DME and CSI definitely work if you know how to do it. If you don't know how to do it, you might not get the same result or the good result. And we now increasingly know that you need to treat some normal retina, which is again is something different from what we used to believe. The same thing, if you treat a dead thing, then they're dead. No matter what you do, they're still dead. So you need to treat something which is kind of working or actually working. And if I stimulate them, that might be the case. Branching occlusion, macroaneurysm, it seems to work. And PCV and drusen removal, that is something that we think that it would work. However, that if it does work for RP as well as for prevention of CNV conversion of wet AMD, and it would be amazing. But I think that we need to do a little bit more work before that we get there. I think that we're going to take all the questions afterwards. And so for the moment, thank you very much for your attention.